Inflammatory bowel disease, IBD. Introduction. The term inflammatory bowel disease, IBD, describes a group of disorders in which the intestines become inflamed. It has often been thought of as an autoimmune disease, but research suggests that the chronic inflammation may not be due to the immune system attacking the body itself. Instead, it is a result of the immune system attacking a harmless virus, bacteria, or food in the gut, causing inflammation that leads to bowel injury. Definition. Inflammatory bowel disease, IBD, is an idiopathic disease caused by a deregulated immune response to host intestinal microflora. It results from a complex interplay between genetic and environmental factors. The two major types of inflammatory bowel disease are ulcerative colitis, UC, and Crohn disease, CD. Inflammatory bowel disease, IBD, is a term for two conditions, Crohn's disease and ulcerative colitis, that are characterized by chronic inflammation of the gastrointestinal, GI, tract. Classification. Ulcerative colitis. Ulcerative colitis is a disease that causes mucosal inflammation and sores, ulcers, in the lining of the large intestine, colon. Crohn's disease. Regional enteritis. Crohn's disease is a chronic, relapsing and remitting inflammatory disease of the gastrointestinal tract, affecting any site from mouth to anus. Difference between Crohn's disease and ulcerative colitis. Crohn's disease. Ulcerative colitis can affect any part of the GI tract, from the mouth to the anus. Most often it affects the portion of the small intestine before the large intestine, colon. Occurs in the large intestine, colon, and the rectum. Damaged areas appear in patches that are next to areas of healthy tissue. Damaged areas are continuous, not patchy, usually starting at the rectum and spreading further into the colon. Inflammation may reach through the multiple layers of the walls of the GI tract. Inflammation is present only in the innermost layer of the lining of the colon. Etiology. The exact cause of inflammatory bowel disease remains unknown. Previously, diet and stress was suspected, but now doctors know that these factors may aggravate but don't cause IBD. The exact cause of IBD is unknown, but IBD is the result of a defective immune system. A properly functioning immune system attacks foreign organisms, such as viruses and bacteria, to protect the body. In IBD, the immune system responds incorrectly to environmental triggers, which causes inflammation of the gastrointestinal tract. There also appears to be a genetic component. Someone with a family history of IBD is more likely to develop this inappropriate immune response. Risk factors. Age. Most people who develop IBD are diagnosed before they are 30 years old. But some people don't develop the disease until their 50s or 60s. Race or ethnicity. Older whites have the highest risk of the disease. It can occur in any race. If client is of Ashkenazi Jewish descent, his risk is even higher. Family history. Client is at higher risk if he has a close relative, such as a parent, sibling or child, with the disease. Cigarette smoking. Cigarette smoking is the most important controllable risk factor for developing Crohn's disease. Non-steroidal anti-inflammatory medications. These include ibuprofen, Advil, Motrin IB, others, naproxen sodium, Aleve, diclofenac sodium, Voltaren, and others. These medications may increase the risk of developing IBD or worsen disease in people who have IBD. Living environment. If a person lives in an industrialized country, he is more likely to develop IBD. Therefore, it may be that environmental factors, including a diet high in fat or refined foods, play a role. People living in northern climates also seem to be at greater risk. Clinical manifestations. Clinical symptoms are same in both case. Diarrhea, abdominal pain, cramping and bloating due to bowel obstruction. Hematochezia, blood in stool. Low fever. Decreased appetite. Weight loss and anorexia. Fatigue. Arthritis. Pathophysiology. Diagnosis. History taking. Take a complete medical, surgical, personal and genetic history. Physical examination. The main features to look for are oral apoptosis, ulcer, abdominal tenderness and masses, anal fissure and fistulae, nutritional deficiency. An important feature in children is growth retardation. Biopsy. Rectal and colonic biopsies should be examined to find the nature of the inflammation, ulcerative colitis versus CD, collagenous colitis or microscopic inflammation if macroscopic appearance is normal, and infection. Blood tests. Tests for anemia or infection. The doctor may suggest blood tests to check for anemia, a condition in which there aren't enough red blood cells to carry adequate oxygen to tissues, or to check for signs of infection from bacteria or viruses. Fecal occult blood test. Client may need to provide a stool sample so that doctor can test for hidden blood in stool. Hypoalbuminemia suggests severe disease with denutrition. The best markers of inflammation severity are elevation of the C-reactive protein and platelet count. Anti-Saccharomyces cerevisiae antibodies, ASCA, are positive in 50 to 60% of CD patients, while anti-neutrophil polynuclear antibodies, ANCA, are positive in 50 to 60% of UC patients. Endoscopic procedures. Colonoscopy. This exam allows doctor to view the entire colon using a thin, flexible, lighted tube with an attached camera. During the procedure, doctor can also take small samples of tissue, biopsy, for laboratory analysis. Sometimes a tissue sample can help confirm a diagnosis. Flexible sigmoidoscopy. The doctor uses a slender, flexible, lighted tube to examine the rectum and sigmoid, the last portion of the colon. If the colon is severely inflamed, the doctor may perform this test instead of a full colonoscopy. Upper endoscopy. In this procedure, the doctor uses a slender, flexible, lighted tube to examine the esophagus, stomach and first part of the small intestine, duodenum. While it is rare for these areas to be involved with Crohn's disease, this test may be recommended if client is having nausea and vomiting, difficulty eating or upper abdominal pain. Capsule endoscopy. This test is sometimes used to help diagnose Crohn's disease involving the small intestine. Client swallows a capsule that has a camera in it. The images are transmitted to a recorder he wears on his belt, after which the capsule exits body painlessly in stool. Balloon-assisted enteroscopy. For this test, a scope is used in conjunction with a device called an overtube. This enables the doctor to look further into the small bowel where standard endoscopes don't reach. This technique is useful when a capsule endoscopy shows abnormalities, but the diagnosis is still in question. Imaging procedures. X-ray. If client has severe symptoms, the doctor may use a standard X-ray of abdominal area to rule out serious complications, such as a perforated colon. Computerized tomography, CT, scan. Client may have a CT scan, a special X-ray technique that provides more detail than a standard X-ray does. This test looks at the entire bowel as well as at tissues outside the bowel. CT enterography is a special CT scan that provides better images of the small bowel. This test has replaced barium X-rays in many medical centers. Magnetic resonance imaging, MRI. An MRI scanner uses a magnetic field and radio waves to create detailed images of organs and tissues. An MRI is particularly useful for evaluating a fistula around the anal area, pelvic MRI, or the small intestine, Mr. enterography. Unlike a CT, there is no radiation exposure with an MRI. Radiology barium enema swallow. USG. Medical management. The goal of inflammatory bowel disease treatment is to reduce the inflammation that triggers your signs and symptoms. In the best cases, this may lead not only to symptom relief but also to long-term remission and reduced risks of complications. IBD treatment usually involves either drug therapy or surgery. Anti-inflammatory drugs. Anti-inflammatory drugs are often the first step in the treatment of inflammatory bowel disease. Anti-inflammatories include corticosteroids and aminosalicylates, such as mesalamine, Asacol HD, Delzicol, others, Balsalazine, colazole, and olsalazine, the pain term. Which medication you take depends on the area of your colon that's affected. Immune system suppressors. These drugs work in a variety of ways to suppress the immune response that releases inflammation-inducing chemicals in the intestinal lining. For some people, a combination of these drugs works better than one drug alone. Some examples of immunosuppressant drugs include azathioprine, azcin, imurin, mercaptopurine, purinethal, puricin, cyclosporine, gangraf, naoral, sandimune, and methotrexate, Trixil. One class of drugs called tumor necrosis factor, TNF, alpha inhibitors, or biologics, works by neutralizing a protein produced by immune system. Examples include infliximab, Remicade, adalimumab, Humira, and golimumab, Simponi. Other biologic therapies that may be used are natalizumab, Tizabri, vedolizumab, Entyvio, and ustekinumab, Stelra. Antibiotics. Antibiotics may be used in addition to other medications or when infection is a concern, in cases of perianal Crohn's disease, for example. Frequently prescribed antibiotics include ciprofloxacin, Cipro, and metronidazole, Flagyl. Other medications and supplements. In addition to controlling inflammation, some medications may help relieve signs and symptoms. Depending on the severity of IBD, doctor may recommend one or more of the following. Antidiarrheal medications. A fiber supplement, such as psyllium powder, metamucil, or methylcellulose, Citrucel, can help relieve mild to moderate diarrhea by adding bulk to stool. For more severe diarrhea, loperamide, Imodium 80, may be effective. Pain relievers. For mild pain, doctor may recommend acetaminophen, Tylenol, others. However, ibuprofen, Advil, Motrin IB, others, naproxen sodium, Alev, and diclofenac sodium, Voltaren, likely will make symptoms worse and can make disease worse as well. Iron supplements. If client has chronic intestinal bleeding, he may develop iron deficiency anemia and need to take iron supplements. Calcium and vitamin D supplements. Crohn's disease and steroids used to treat it can increase risk of osteoporosis, so you may need to take a calcium supplement with added vitamin D. Non-pharmacological treatment. To avoid smoking cessation. To reduce alcohol consumption. To avoid the use of NSAIDs. To avoid spicy and fried oily food. To take fiber-rich diet as tolerated that include tender cooked vegetables, canned or cooked fruits, and starches like cooked cereals and whole wheat noodles and tortillas. To incorporate more omega-3 fatty acids in the diet. These fats may have an anti-inflammatory effect. They are found most probably in fish. Surgical management. Surgery for ulcerative colitis. Proctocolectomy, removing the colon and rectum, with ileostomy, if UC is severe, surgery may be required to remove the entire colon and rectum, plus bring the ileum, end of the small intestine, through a stoma, opening, in the abdominal wall to allow drainage of intestinal waste out of the body. The second part of the procedure is called ileostomy. After the procedure, an external bag must be worn over the opening to collect waste. Restorative proctocolectomy, also known as ileoanal pouch anal anastomosis, IPA. It involves removing the colon and rectum, but the patient can continue to pass stool through the anus. In place of an ileostomy, the ileum is fashioned into a pouch and pulled down and connected to the anus. Surgery for Crohn's disease. Stricturoplasty, if an area of the bowel narrows, this widens the area without removing any portion of the small intestine. Resection, removing portions of the intestines. This involves removing affected areas of the intestine, and then joining together the two ends of healthy intestine in a procedure called anastomosis. Surgery for abscesses and fistulas. Sometimes abscesses, pus-filled mass, need to be removed surgically. And surgery may be required if a fistula, abnormal tract, is causing symptoms that don't respond to medication. Colectomy, removing the colon, or proctocolectomy, removing the colon and rectum. If only the colon is affected, a colectomy may be needed. But if the colon and rectum are affected, a proctocolectomy may be needed, along with ileostomy, bringing the ileum, end of the small intestine, through a stoma, opening, in the abdominal wall to allow drainage of intestinal waste out of the body. After the procedure, an external bag must be worn over the opening to collect waste. Nursing management. Nursing diagnosis. Diarrhea related to inflammatory process. Acute pain related to increased peristalsis and GI inflammation. Imbalanced nutrition less than body requirements, related to dietary restrictions, nausea, and malabsorption. Activity intolerance related to generalized weakness. Anxiety related to impending surgery. Ineffective coping related to repeated episode of diarrhea. Risk for impaired skin integrity related to malnutrition and diarrhea. Interventions. Enhance nutritional status. Promote nursing care of the client who is receiving nothing by mouth, receiving oral fluids, or on total parenteral nutrition during an acute exacerbation. Assess for fluid and electrolyte imbalance. Administer for fluids and electrolytes as indicated. Encourage a low residue, high protein, high calorie diet with supplemental vitamin therapy and iron replacement. Implement measures to treat diarrhea or constipation. Minimize pain. Address and mediate the client's pain. Promote intermittent rest periods and bed rest when the client has acute exacerbations. Promote client and family teaching. Encourage the client to seek psychotherapy to determine the factors that distress the client and how to deal with these factors to prevent exacerbations. Provide client teaching covering the importance of good nutrition and adequate fluid intake. Stress management techniques. Perianal skin care. The need for follow-up visits to the healthcare provider. Administer medications. It includes antidiarrheals, corticosteroids, antibiotics, antispasmodics, and anticholinergic and opioid analgesics. Complications. Ulcerative colitis and Crohn's disease have some complications in common and others that are specific to each condition. Complications found in both conditions may include colon cancer. Having IBD increases risk of colon cancer. General colon cancer screening guidelines for people without IBD call for a colonoscopy every 10 years beginning at age 50. Skin, eye and joint inflammation. Certain disorders, including arthritis, skin lesions and eye inflammation, uveitis, may occur during IBD flare-ups. Medication side effects. Certain medications for IBD are associated with a small risk of developing certain cancers. Corticosteroids can be associated with a risk of osteoporosis, high blood pressure and other conditions. Primary sclerosing cholangitis. In this condition, inflammation causes scars within the bile ducts, eventually making them narrow and gradually causing liver damage. Blood clots. IBD increases the risk of blood clots in veins and arteries. Complications of Crohn's disease may include bowel obstruction. Crohn's disease affects the full thickness of the intestinal wall. Over time, parts of the bowel can thicken and narrow, which may block the flow of digestive contents. Malnutrition. Diarrhea, abdominal pain and cramping may make it difficult for client to eat or for intestine to absorb enough nutrients to keep you nourished. It's also common to develop anemia due to low iron or vitamin B12 caused by the disease. Ulcers. Chronic inflammation can lead to open sores, ulcers, anywhere in digestive tract, including mouth and anus, and in the genital area, perineum. Fistulas. Sometimes ulcers can extend completely through the intestinal wall, creating a fistula, an abnormal connection between different body parts. Fistulas near or around the anal area, perianal, are the most common kind. In some cases, a fistula may become infected and form an abscess. Anal fissure. This is a small tear in the tissue that lines the anus or in the skin around the anus where infections can occur. It's often associated with painful bowel movements and may lead to a perianal fistula. Complications of ulcerative colitis may include toxic megacolon. Ulcerative colitis may cause the colon to rapidly widen and swell, a serious condition known as toxic megacolon. A hole in the colon, perforated colon. A perforated colon most commonly is caused by toxic megacolon, but it may also occur on its own. Severe dehydration. Excessive diarrhea can result in dehydration.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.